magnesium sulfate may be difficult in the loading dose. You at least can give intramuscular magnesium sulfate 5 grams in each buttock and then refer. If you cannot give IV loading dose, give the IM part 10 grams, 5 grams in each buttock IM and then refer her. And magnesium sulfate should be given when the blood pressure is severe, even if she doesn't have convulsions. That's very important. Give the antihypertensive and the anticonvulsant dose and then refer her immediately. That is what is recommended. So, why is it important? Why is it important that we act in time? Because women with hypertension in pregnancy at any point of time, because it's a multi-system disease and the disease is because of the placenta, unless she delivers, she will not, the disease processes will go on continuing. That is one thing which we should always remember. Giving antihypertensives will only temporarily mask the blood pressure. It won't correct the underlying pathophysiology. And the various maternal complications that can occur are abruption. The case 1, she developed abruption. And related to abruption, she developed renal failure, disseminated intravascular coagulation. And she may develop eclampsia, pulmonary edema, stroke, cerebrovascular accidents, all of which can lead to abruption, hemorrhage, dick hemorrhage. All these things can lead to death of the mother. And even if she survives after such serious complications, studies have now shown that there is a long-term morbidity to the woman, neurological as well as cardiovascular. Morbidity is common in these women, even in those who survive. So if we act in time, we can prevent all these complications. We can prevent maternal death and we can even prevent maternal morbidity in the long run. So let's see the second case. The first case, she developed hypertension at 36 weeks. This woman, she's a preemie with expected date of delivery on 17th of July. On 8th of June at 34 weeks, she developed first blood pressure was first recorded to be 1. This was again during her regular antenatal checkups. It was found to be 140/90 at 34 weeks. And she was again prescribed antihypertensive and sent home. And within 1 week, 34 weeks, 140/90. Within 1 week, she developed convulsions. And that's the rapidness of the progression in this condition which you have. This is what I wanted to tell you, that impress upon, that it can become, hypertension can become severe at any point of time. It may become very severe within a few days itself. Okay. So she was referred with convulsions. Initially magnesium sulfate was given and then she was referred at 10:30 a.m. on the same day. By the time she came, she was unconscious with the convulsions. And when the investigations were done, they showed that she had renal and liver failure as well as thrombocytopenia. So she was delivered. She didn't succumb immediately. She was there on supports, and we tried to recover her. She was in the IRCU for about 2 weeks, but finally she expired on 29th of June 2021. We couldn't save her despite all the supportive measures, and the cause of death was antepartum eclampsia with acute renal kidney injury with HELLP syndrome. So the same in this case also. What could have been done? So the first case was at 36 weeks. This at 34 weeks. The first recording was 140/90. Within 1 week, she developed eclampsia. It's just like the homework, like repeating. So from what we have discussed from the first case, what could have been done in this case?
We need to refer her to higher center.
Why? What's the aim? Why should we refer?
For investigations.
For investigations and most importantly, I want you all to understand
termination of pregnancy.
Termination of pregnancy. She needs investigation, stabilization, immediate termination at 34 weeks also. Okay, don't think about the baby. She's 34, we have to go till 37. There's nothing like that, especially for hypertension complicating pregnancy.
Once hypertension is diagnosed,
We cannot say which is severe, not severe. What is written in the book is keep it aside. You are sitting on a volcano. As a bomb, ticking bomb, we don't know when it's going to burst. So it's so important that once you diagnose, you have to plan either referral and expedite delivery. Okay.
So the reason, the thing you all know, all the PHC medical officers know, refer. But why? You should understand the disease also. It's important to understand the disease, how it's going to behave. Then once we know why, then we'll be able to refer more promptly. We should know why we are doing that. Should understand the disease. Termination of pregnancy is very, very important in irrespective of the period of gestation, depending upon the disease progression. That assessment will be done at the tertiary care. Okay. So, timely action is very, very important. So, let's see the third case. She was a gravid to the previous one abortion. Her LMP was on 1st September 2020 and her expected date of delivery was on 8th June 2021. Even she was under regular antenatal checkups. Gestational hypertension was diagnosed on 9th of March 2021. See here, her expected date of delivery was on 8th June, and hypertension was first diagnosed on 9th March. That was around 28 weeks. Early onset hypertension is very, very dangerous. There are two types of hypertension, early onset and late onset. Late onset usually develops at almost close to term, like 36 weeks or 30. So mother and baby both, if we act immediately, both mother and baby are fine. But acting immediately is important always. I keep on stressing. Here the dilemma comes. You will think, oh, she is only 28 weeks. The baby cannot be survived. So I'll try to give her antihypertensives and see and prolong the pregnancy till I can save the baby also. That may be your thinking, but that should not be there, especially in early onset hypertension, which is more likely to become very severe with serious consequences. That is more common with early onset than late onset. So be cautious. Don't think about the baby. Okay. So what happened was they asked her to come back. Another visit was done after 10 days. I have seen in the review. So she was started on immediately. She was started on labetalol, sent home and reviewed again on 19th March. Then they found that the hypertension is under control, and again they sent her back home. This was at the PHC level only. On 6/4, 9/3/6/4. That then she was around 32 weeks. She presented with convulsions. Okay. And from that PHC, they immediately sent her to area hospital Narsipatnam. They gave her, by that time itself, she was convulsing repeatedly, Magnesium sulfate was given. And then she reached area hospital Narsipatnam in the morning. And by 10 o'clock, or by around 7 or so, and they immediately referred, she reached KGH immediately. But she was unconscious at the time of admission itself. Intrauterine fetal death was there. Because anyhow, with such early onset severe hypertension, placental insufficiency, anyhow we cannot save the baby. And pulmonary edema had set in. Okay. Luckily, she went into labor once she delivered, but she didn't recover from the pulmonary edema and from the cerebral complications, and she expired within 24 hours. So she died from antepartum eclampsia and pulmonary edema and cerebral also, and she had renal failure also. So this case, she developed hypertension at a very early stage. Remember that, irrespective of the period of gestation. If it's very early, remember, you have to drag on for so many weeks to get the baby. In such cases, you have to be very firm. Tell that the mother is more important. You have to counsel. Don't think about the baby. Have to deliver the mother immediately. So that's what actually I came out before itself. What could have been done to prevent this? All these three outcomes, especially, we felt from our department, all three were very, very preventable if we would have acted in time and referred in time and delivered them immediately. I hope. Do you all agree? All the participants, do you agree with us?
Yes, ma'am.
Definitely, do you agree?
Yes, ma'am.
And I hope the message has been conveyed. Is it clear?
Yes, ma'am.
You all should be very free to interact. Any doubts you can ask very freely. Okay. Just we are putting these case studies which have happened really, and so that we can learn something from that, and we can help the patients. So let's see. I'll tell some basic things which can be done by us, okay, at the PHC level also. So any disease we have learned from SPM that prevention is better than cure. So first of all, is hypertension in pregnancy preventable? Is it preventable? Let's see. We know preeclampsia develops later progresses to eclampsia. I hope you all know. Is it not? Do you remember from your MBBS days about preeclampsia and eclampsia? I'm asking the participants, the medical officers.
Yes, ma'am.
Yeah.
Yes, ma'am.
So preeclampsia is not always preventable. We all agree, not always preventable. But the most important thing is most of the complications associated with preeclampsia are preventable, like eclampsia, HELP, abruption, DIC, cerebrovascular complications. Do you think all these are preventable or not?
Yeah.
These,
Yes, ma'am. Yes, ma'am.
these complications which we are seeing, the woman dying from these complications, are these preventable?
Yes, ma'am.
Yeah. We know hypertension in pregnancy is not preventable, 100% preventable because it is because of the placenta.
Yes.
So hypertension we may not prevent in all women, but the complications of hypertension are preventable. So eclampsia is definitely 100% preventable. So prevention. So what is in our hands in terms of what can we do at least to prevent to some extent? Again, I'm telling preeclampsia is not 100% preventable disease. Lot of research is being done to find out ways to predict and prevent preeclampsia in women. So more tests to predict that this woman is likely to develop hypertension later in her pregnancy and do something to prevent that. There are certain interventions that can be done to prevent, not 100%, but to some extent to prevent the development of hypertension. One most important thing is identification of women with risk factors who are likely to develop hypertension later in their pregnancies. To identify, we should know the risk factors and we must screen them for these risk factors when they come at booking. Is it not? So we have to screen them for the risk factors. Nulliparity itself is a risk factor. And young primary and an elderly, extremes of maternal age, pregnancy at extremes of maternal age is a risk factor. Multiple pregnancy is a risk factor. Having hypertension in her previous pregnancy is again a risk factor. Family history is very important. Family history of preeclampsia is a risk factor. Associated medical chronic hypertension and renal disease are risk factors. Overweight, being overweight is a risk factor. PCOS is a risk factor for hypertension in the pregnancy. Developing pre-gestational diabetes and gestational diabetes, both are risk factors for development of hypertension in pregnancy. Smoking is a risk factor. Other disorders, medical disorder like SLE, autoimmune disorders like SLE and antiphospholipid syndromes are risk factors. And we all know even hydrated formol is a risk factor. So we should all remember the risk factors, screen the woman for risk factors. Even National Health Mission, NRHM, has brought out guidelines for screening for hypertension. They have given a big list of risk factors which can be, topic is given regarding screening for hypertension in pregnancy, which can be downloaded also from Google. So in the prevention, screening for risk factors is one thing which is important. The other thing is drugs. So do drugs have a role in prevention? Yes. Aspirin and calcium have a role in the prevention, definitely. In our calcium in our country, especially, I feel definitely has a role. So regarding aspirin, studies have definitely proven that giving aspirin has a preventive role in prevention of hypertension. But again, it's only in those who have risk factors. It's not like just because aspirin prevents, why don't we give aspirin for everybody from 12 weeks? It is not, because it has its own side effects. That particular role for giving aspirin as a routine has not yet been advocated. It's not to be done. But those who are at risk, for them, we are supposed to give aspirin. The dosage is 150 milligrams of low aspirin, which has to be started after 12 completed weeks of pregnancy, and it is to be given at bedtime. So this has a role in the prevention of hypertension in women who have risk factors for development of hypertension. later in pregnancy, not to be used as a routine as of now. That's another thing you all must remember. And role of calcium. Studies have shown that in populations who are deficient, whose diets are likely to be deficient in calcium, calcium supplementation definitely has a role in prevention of hypertensive disorder, hypertension pregnancy. So 2 grams per day of calcium in women who are likely to consume diets low in calcium, it will have a preventive role, a very simple measure. And I feel our women are definitely, I hope you all also accept that most of our women, the diets will be deficient in calcium. Among the socioeconomic status that we see, the settings that we work in, women are likely definitely deficient in their diets. So, adequate calcium supplementation, aspirin 150 milligrams from 12 weeks onwards, in those, and screening for risk factors is very, very important. And risk factors, I'm telling, it's a very beautiful screening for its hypertensive disorders in pregnancy. Government of India has brought out guidelines available, can be downloaded from Google, from net. So how to prevent the disease is one thing. So we have seen that. And we also know that the disease cannot be prevented 100%. So once the disease occurs, develops, the next aim for us is prevention of mortality due to the disease. That is our aim. First, try to prevent the disease. If the disease has occurred, try to prevent complication, mortality and morbidity due to the disease. For this, early diagnosis and prompt action is the key. That's what we wanted to stress upon. Early diagnosis and prompt action is the key. By doing this, most of the deaths due to hypertension in pregnancy can be avoided, which is responsible for 25% of the maternal deaths in our country. So this is one thing you all should remember. This particular condition, signs appear before symptoms. So something which we as doctors are we have to elicit. Symptoms, the patient will come to us with. Normally, if she has a fever or anything, she'll come with the symptoms and then we'll investigate. But here in this particular condition, signs appear before symptoms, like rise in blood pressure, abnormal weight gain, non-dependent symptoms like headache, epigastric pain, blurring of vision, reduced urine output, and convulsions appear late. They indicate that the complications have already set in. So, identifying before complications set in is very, very important. Signs appear before symptoms, that you all must remember. So, rise in blood pressure is the one thing that is diagnostic, that appears early, and you are supposed to correctly pick up the disease when it starts developing. So recording BP is blood pressure in pregnancy is very, very important. If I don't know whether you can record BP individually up to, you can record the blood pressures of all the antenatal women who attend your OP. If you are not recording yourself, please train your staff properly, supervise on a regular basis that they are recording the blood pressures correctly. Please check sometimes at least. Please keep on checking. See that they record, they are doing it on a regular basis. The baseline blood pressure and recording blood pressure at every antenatal visit. Let it be a primary or a multi, because over the past few years, we have been seeing in KGH, it's no longer a disease of primaries. We are seeing it quite commonly even in multis also. So please keep recording BP. Please record. Every pregnancy is important. Every pregnant woman you have to consider, you have to take care, provide good antenatal care. That is very, very important. According to guidelines, provide ideal antenatal care. Please record blood pressure at every visit. Train your staff properly recording blood pressure. And especially many of our places are in tribal areas, remote, inaccessible areas. In such places, I think locally educated women should be picked up as ashas by the government. They should be trained in recording blood pressures, provided blood pressure apparatuses, and they should be those who are staying in inaccessible tribal areas. For such antenatal women, local educated women should be trained for recording their blood pressures. I feel that's what we felt actually when me and Dr. Usha were discussing. So this particular aspect, I think the medical officer should insist, should oversee it and supervise on a regular basis. And there is also a condition known as delta hypertension. This a word about this. I think for some women, their baseline blood pressure is at booking could be around 90, 100 by 70 or something like that. So as pregnancy progresses, if it is around 90, 70 or something, and as pregnancy progresses beyond, especially we have to be cautious, gestational hypertension is high blood pressure recorded for after 20 weeks of pregnancy. If high blood pressures are recorded before 20 weeks, it is considered as pre-existing chronic hypertension. So if her blood pressure starts raising, if the raise in systolic of about 30, if it is 90, it will come to 120. If it is 70, diastolic 70, it may come to 85 or something. So if there is a marked rise in systolic and diastolic blood pressures compared to her baseline blood pressure, be cautious in such women also. Please be cautious. If she is gaining weight abnormally or if she is developing edema, be cautious. Be very cautious. Okay, because this simple measure of recording blood pressure will save so many lives. So record blood pressure because that is the most important diagnostic test for hypertension in pregnancy, which is a very preventable, disease, which preventable cause of maternal mortality. And then refer the woman, timely referral. Please remember about timely referral. That is very, very important. Because again, I'm telling you, irrespective, we have seen 3 cases where one woman, she developed hypertension late 36 weeks. Even then, decision for referral and delivery was not taken. Maybe they were thinking another 4 weeks is left. That's one thing. And again, a woman, she developed hypertension was recorded for the first time at 28 weeks. And she developed complications at 32 weeks itself and she died. So at one woman, she developed at 34 weeks and within 1 week, her disease became severe within 1 week and she succumbed. Remember all these situations. So the disease can become severe at it can be fulminant. It can become severe severe very fast. That is one thing which we must all remember. And the definitive treatment for hypertension in pregnancy, the definitive treatment is delivery. That you all must remember. It is not giving antihypertensive. That is not the treatment for pregnancy hypertension. It is not for non-pregnant women. For chronic hypertension, you give hypertension, blood pressure is controlled, so we'll be happy. But not here. Here the situation is completely different. The disease is in the placenta. The pathophysiology is because of the pregnancy. So it's a completely different pathophysiology. So the definitive treatment to save the mother is delivery. So this is what we wanted to convey. Thank you very much for giving us this opportunity. Our HOD, Dr. Nagmani Madam, and our Professor, Dr. Uma Madam, and Dr. Usha, Superintendent VGH have also joined. Anything else to be added, Madam? Nagmani Madam?
Vidya, you have done very well, and I think the medical officers must have clearly understood about the importance of doing the blood pressure examination, and then the most important thing what you have to remember is when a woman comes with mild hypertension, if you give antihypertensives, her blood pressure will become normal, 120 by 80. And you take it light. You think that she is fine. So that is where the mistake is going on. All of you must have understood by now. And so what we do at KGH, so that you will remember, why I am telling you is you will remember, because whenever a woman comes in OP and we have done a BP examination 140/90, what we do is we have to admit them first. First we admit them and to look for any serious signs, other signs and other investigations, and everything is fine. And if she is reachable, then only we will discharge her. Okay, so don't go into false sense of security that she is fine by giving antihypertensives. So this is what Vidya has said. So because you're in a remote area, if her blood pressure is high, just tell them. Just tell them. You may give her antihypertensives, but it doesn't mean that she is fine. And then tell her that she may die of pregnancy complications. So that's what you have to communicate, because people will think that her blood pressure is fine and there is no need to go anywhere. But what you have understood from this presentation, that even mild hypertension can lead to severe complications within a period of few weeks. So this is what you have to impress upon all your patients and their attendants. If she doesn't listen, just call her attendants and then convey them. If you cannot tell the patient directly that she is going to die, you have to tell her attendants that you have seen many patients dying within 2-3 weeks. Then they will know the importance of going to a proper place for further evaluation. Okay.
As Madam said, we should be relatively quite blunt, I think, in putting forward in such situations.
Yes,
We are not.
yes.
We should be very blunt in telling them that she might, if not directly to the patient, her attendance.
Yes.
And also, as we discussed in our previous meetings in the DMH office and with the collector, we have to inform the higher authorities immediately if they're not willing.
Yeah, you have to take the number, phone number, and then contact number, and the ASHAs have to be immediately informed because they are all in your areas only. If they are not listening and then just going home, just note them. That's what we are also doing in the KJHOP. Somebody comes with high blood pressure, they just leave the place. So once we come to know that she needs an admission, what we do is we just note them, their numbers and contacts in the register. And then immediately we inform it to the DPHNO because we cannot reach the patients outside. But you people can reach your patients. So it's nice that they belong to your place. You can always reach them. Don't leave them just because they don't agree.
Yeah, another thing I request all the medical officers to please keep on continuously training your staff regarding the importance of diagnosing hypertension and picking them and informing you. You must know. That's very important. Please be in constant touch. Please keep on repeatedly educating your health staff who will be at the ground level. The importance of reporting it to you back if they find that the blood pressure, if she has a doubt that the blood pressure is on the higher side, and train them well in recording blood pressures.
If anybody has any doubts, they can come up with your doubts.
BP apparatuses, are they very easily available?
Madam, an excellent enlightening presentation by Vidya Rama, madam. I think after that, all the medical officers will know what to do. They'll know the path, which path to tread. Excellent presentation, madam, by Vidya.
Here I should tell that Dr. Usha has helped me. We did it together, the presentation actually. Both of us, we put our ideas together. She guided me into preparing this presentation.
Very well done, both of you.
I'm doing this from VGH superintendent's room, madam.
Yeah, I know. I can see that. And then from now, all the medical officers should be very careful whenever they come across a hypertension patient. And I think we should not see many complications from now. Complications are bound to be there,
Yeah.
but you should understand that the woman should not die of a complication.
Of complication and something that has not left unattended. In spite of all your attention and services, she might still not come through. But that's beyond us.
Yes, ma'am.
See to it that the rules have been followed meticulously and the early referral and warning is
Yes, madam. Yes,
you could still lose the patient. That's not really in our hands.
Yes, we did what we had to do. That is important.
Thanks a lot. Thanks a lot.
Yes, ma'am. Dr. Vijayalakshmi, Dr. Vasundhara. So, if there's any other doubts or
Madam, that was an excellent presentation and very informative and very useful to everyone, madam. You made the whole subject very simple to understand and very practical to implement. Thank you so much, ma'am. We are looking forward for more such interactive sessions. Thank you.
Thank you.
సో మెడికల్ ఆఫీసర్స్ ఎవరికైనా ఏదైనా డౌట్ ఉంటే మేడం తో మాట్లాడండి అమ్మా. లేదు అన్నా కూడా మనకు గ్రూప్స్ ఉన్నాయి, మనకు 6 మెంటారింగ్ గ్రూప్స్ ఉన్నాయి. ఈ 6 మెంటారింగ్ గ్రూప్స్ లో రెగ్యులర్ గా మన మేడమ్స్ అందరూ కూడా, మన మెంటర్స్ అందరూ కూడా మనకు టచ్ లో ఉంటున్నారు, ఇమ్మీడియట్ గా రెస్పాండ్ అవుతున్నారు. ఇన్ కేస్ ఏమైనా వారు ఓపీలో ఉండి మీకు మీ మెసేజ్ చూడలేకపోతే డైరెక్ట్లీ ఇఫ్ ఇట్ ఈస్ అన్ ఎమర్జెన్సీ కేస్ గివ్ దెమ్ ఏ కాల్. చాలా దే ఆర్ వెరీ రెసెప్టివ్ అండ్ వెంటనే రెస్పాండ్ అయ్యి మనకి సొల్యూషన్స్ కూడా ఇవ్వడం జరుగుతుంది. అండ్ మన చాలా హై రిస్క్ కేసెస్ కి ఈ మధ్య కాలంలో ఇమీడియట్ రెస్పాన్స్ ఇవ్వడం వలన మంచి డెసిషన్స్ తీసుకొని ప్రాపర్ అవుట్కమ్ కూడా ఇవ్వగలిగాము ఈ లాస్ట్ 15 to 20 days లో. I hope every medical officer is continuously in touch with these mentoring groups and utilizing the services given by our professors and associate professors from gynecology department. Thank you Andy from my side. DM and HO madam, if she is on the line, I think madam chala busy ga unnaremo. I think madam ena cheptaru.
Madam, just Vasundhara madam, just one word I want to tell all the medical officers. They should never think that they are disturbing us. Day aina, night aina, anytime, we are just ready to respond. And if you think that WhatsApp ki time ledu anukunte, please give us a call. For every mother matters to us. Each and every mother matters a lot. So I just want to put in a word, because all medical officers are there at this point of time. Please, all of you, don't hesitate to call us. Because patient's life is important. Thank you.
Somebody is asking.
Somebody is responding. Yes.
Ma'am, good evening, ma'am. I'm medical officer Anantiri, ma'am. Dr. Sandhya. Last week, one of our case was absconded from KGH second unit, ma'am. She's having BP readings with 130/90 and it's fluctuating, ma'am.
Where is she now?
She is present with us, ma'am. We are referring her tomorrow, ma'am.
Yes. This case, this is very important. When you're referring, please talk to the second unit assistant. Please be in touch with the doctors also.
Ma'am, on the next day, we find out at that, ma'am. We gave counseling her to admit in KGH, but she refused, ma'am. So she refused, and again we brought her today and again gave counseling. She was willing to go tomorrow.
Okay.
I discussed with the concerned gynecologist and treatment. We are following the treatment advised by gynecologist, ma'am, Dr. Kamla.
Yeah, very good then. That's good. This is a good feedback. So it's working.
What is the gestation age?
33 to 34 weeks, ma'am.
Then what are the latest blood tests? Have you done any blood tests?
No, ma'am. Ma'am advised to do urine. What, ma'am?
What was the last test? Because surveillance is required, no? So
Yes,
pregnant woman is with you, fetal and maternal
17th,
surveillance.
Pardon? On 17th, she was absconded, ma'am.
Yes, but what I'm asking is, when was the last blood test done for her?
On 16th. On 16th at KGH. It was, yeah, ma'am, it's normal, ma'am. All reported investigations are normal, ma'am.
Please send her as early as possible to us. I told you not to
tomorrow we are referring her, ma'am.
As early as possible. Please send her back. If she doesn't respond, please let us know. Please let second unit of KGH know what's happening, so that we can inform the manager.
Okay, ma'am.
Okay, ma'am. Thank you.
Thank you.
Okay then. Thank you very much. So can leave the meeting now, no?
Thank you.
Okay.
Thank you Vidyarama and thank you Usha. So chala detailed ga ba present chesaru. So all the medical officers ku one request. Madam cheppina points lo BP recording is most important అని చెప్పారు. సో మన దగ్గర PMSMA రోజు వచ్చినప్పుడు డెఫినెట్ గా మెడికల్ ఆఫీసర్స్ BP రికార్డ్ చేస్తే మనము ఏ కేసు కూడా మిస్ అవ్వము. దీన్ని కొంచెం అందరూ జాగ్రత్తగా ఫాలో అవ్వండి. దిస్ ఈజ్ మై సైడ్ రిక్వెస్ట్. తర్వాత మేడం గ్రూప్ లో యాక్టివ్ గా ప్రతి కేసు కూడా రెస్పాండ్ అవుతున్నారు. సో ఎవరికైనా ఎటువంటి డౌట్ ఉన్నా ఇమీడియట్ గా గ్రూప్ లో పోస్ట్ చేయండి, లేదా డైరెక్ట్ గా మెసేజ్ ఫోన్ అయినా చేయండి. మీకు ఎటువంటి హెల్ప్ కావాలన్నా ఇక్కడ డెమోన్స్ట్రేషన్స్ లో మాకు కానీ లేకపోతే డిపిహెచ్ఓ కానీ ఫోన్ చేయండి. ఇప్పుడు మనకు మేడం కేజీహెచ్ మేడం ఉన్నారా, నాగమణి మేడం ఉన్నారా, జూమ్ లో ఉన్నారా?